Let's begin with the first section of Introduction to Emergency Medicine. And in this section, we will discuss about the clinical scope of the problems, general categories of problems or complaints, anatomic essential, and also patient history. So first, what is emergency medicine? Why we say it's emergency? Patient needs to go to the emergency room or ER. So emergency encompasses initial evaluation, treatment and disposition of any person at any time for any symptoms, event or disorder deemed by person or someone acting on his or her behalf to require expeditious medical, surgical or psychiatric attention. So it's important we should know what is an emergency situation. In emergency, the patient is in emergency and needs to be seen by the surgeon, physician, attendant who is in the emergency room as soon as possible, and it is the situation in which the normal initial evaluation, physical examination that is performed by the doctor as an outpatient in the OPDs, outpatient department, those are that are passed over, or it is encompassed by the patient, and if somebody is attending the patient or whoever is present in emergency, usually in serious emergency, if the patient is coming to the emergency room with the ambulance is bringing the patient, so they go directly to the emergency room. But even the attendants who are coming with the patient, they need to know that this is an emergency situation, and they need to pass the normal procedure that is fixed for the patient who are in the outpatient department or who are not in emergency situation. In the emergency department, there is a triage. It's known as the triage that is followed. Triage is the patients seen according to the seriousness of their condition. That's why lots of time patients who are not in emergency or who are not in that serious critical situation, when they go to emergency room, you always see them, they are complaining that, oh, I was sitting there for 3, 4, 5, 6 hours and nobody was attending me because they were not in the triage on top. And usually in emergency room, patients who are very, very serious, they are seen first. And patients with common cold and slight fevers, usually they have to sit there for hours, because emergency rooms means the patients who need emergency care. So it's very important that we should know the difference between emergency and a routine checkup, because usually patients like to go to emergency room for any simple complaint they have. So it encompasses initial evaluation. We don't need to go for the initial evaluation and need to waste time. So we need, in emergency, patient need expeditious medical, surgical, or psychiatric attention. So even psychiatric patients, they have emergency also when they are really, really bad and aggressive and danger for the other patients, people, and they are suicidal. So we need emergency treatment for all medical conditions, surgical condition, and psychiatric conditions. Emergency department or ED emergency physicians. Make sure for emergency patients, there is a separate department where we have all the facilities available. There are emergency physicians on duty 24/7 to handle the patients who come in the emergency department. So emergency medicine, when we say emergency medicine, it has all the emergency department, it has emergency physicians, qualities of emergency physicians. It's very important that in the emergency department we should have the physicians who need to know how to handle the emergency situation, or they just don't panic when they see the emergency, because usually they are the patient who need the management right away on the spot. So quality of physicians is very important in the emergency department. Challenges, they need to know what are the different challenges they usually face in the emergency department. Then, so clinical scope of the problem. Top 10 reasons for emergency department visits. What are the categories of the patient who usually visit to the emergency department? Abdominal pain is on the top of the list. So patients who have abdominal pain, usually they come to the emergency department most often. Chest pain. Chest pain is also another very important reason. Chest pain, lot of people, they get worried that they might have heart problem, they have chest pain, conditions like angina, heart failure. All these patients, or heart attack, can go to emergency department, and then they are referred to the corresponding wards or areas. So abdominal pain is the number one. On second, we have the chest pain. Fever is very, very common reason, especially very high grade fever. When it reaches 205, 104, usually the person get really upset, and they usually go to emergency department. Headaches, severe headaches, back symptoms, shortness of breath. Shortness of breath can be due to the lungs problem, asthma, other problems, and shortness of breath can be due to the cardiac reason also. So it's very, very concerning. So usually the patients go to the emergency department. Cough, vomiting, really bad vomiting when they cannot take in anything, usually that is concerning. Pain, not just the abdominal pain, any other pain is also one of the common reason. And then we have throat symptoms. So these are 10 most common reasons for visit to emergency department, and these are the conditions, medical conditions besides the accidents and injuries, which are anyway the common cause for the visit to the emergency department in emergency. So abdominal pain, usually there is maybe appendicitis and disorders of ruptures, different things can occur. So abdominal pain, chest pain, fever, headache, back symptoms, shortness of breath, cough, vomiting, pain, and throat symptoms are the common top 10 problems for the visit to the emergency department. General categories of problem or complaints. Pain can be traumatic pain or atraumatic, can be as a result of trauma or without trauma. Pain can occur, and it can be one reason for visit to emergency department. Difficulty with breathing, vision, urination, difficulty with swallowing, difficulty with concentration, speaking, balance, coordination, ambulation sensation. All these are the problems that can lead to the visit to emergency department. Fever, bleeding, which can be painful or painless if it's not more than mild bleeding or little bleeding. Usually patient gets very scared or nervous if they see the bleeding, and they go and run to the emergency department. Then we have some social issues: inability to care for oneself, change in behavior, drug or alcohol related problems, homelessness, and hunger. All these are the categories of problem or complaints that can lead to the visit to emergency department. Anatomic essentials, airway. It's very important when the patient comes to the emergency room, we have airway, breathing, circulation. These are the few steps that needs to be managed right away, and that's also the part of our basic CPR, which is cardiopulmonary resuscitation. That's the person performing CPR. So it's airway, maintaining the airway. Look right away if the person can breathe properly. If the person is not breathing, then you need to go and do emergency tracheostomy to help the patient to breathe. So airway is the first anatomic essential. Look for the patency of the airway. Breathing, if the person is breathing normally or not. Circulation, we can check by the pulse. Pulse is if pulse is okay, or person has pulse or not. Disability and exposure. So these are the A, B, C, D, E of emergency: airway, breathing, circulation, disability, and any exposure to anything. So these are the anatomic essentials. History is very important. Usually we have P is for provocative, palliative, as in what makes this pain worse or better. History is very important. Few questions we need to ask regarding the pain. If person comes with the history of pain, we should ask what makes this pain worse or better, especially with the chest pain. If the patient comes, and we need to ask if the patient walks and the pain get worse and the resting relieves the pain. That's very, very important to differentiate with the angina pain, or it's just due to acid reflux or regurgitation. That can also cause. Then we should ask what makes it, whether food makes it better or whether it is aggravated by eating. So these are some questions we need to ask in emergency. So what makes this pain worse or better? Also, quality of pain. PQ, quality of the pain, as in describe your pain. That's very important. Is your pain sharp or dull? Is the pain sharp or dull pain? The quality of pain is important to ask. R is the region or radiation. What region is the pain? If it's very important, lower right quadrant, left quadrant, upper quadrant, left quadrant, in the center. All these are the different areas in the chest, radiating to the arm, radiating to the neck. In the, if it's in the lower right quadrant, radiating to the umbilical regions, if it's tender or not. Radiation of the pain, very, very important question. What region of your body does the pain occur? Does it radiate or move to any other location, or if it stays there? Pancreatitis pain radiates to the back. All these things are important to ask for the actual, to reach the diagnosis, what the pain is from, originating from what reason. So P, what makes this pain worse or better, which is the provocative and palliative. Quality of the pain, dull or the sharp. Region or radiation, chest pains, heart pains usually radiates to the left side, left arm, or sometimes in the neck. So it's important to ask these questions. Severity is another, how bad it is, and usually you give the number to the patient, okay, how bad is the pain, you should tell us from 0 to 100, you grade it from 0 to 10, and then you ask the patient if it is 1, 2, 5, 6, so you do it from 0 to 10. A happy, sad faces scale, and mild, moderate, or severe. So mild, moderate, or severe, or happy, sad face scale. So these are the scales, P, Q, R, S, and then we go for T. Timing is very important. When did your pain start? After eating, after walking, after going up the stairs, climbing the stairs, or walking few stairs. So all these questions are important. Timing of the pain. What were you doing when your pain started? So it's the important question, and how long did it last? Usually the angina pain lasts for just a few minutes. It's not more than 30 minutes. It usually means we have other issues. So angina pain doesn't last very long. So timing of the pain is important. So PQRST, very important steps in the history that help us to find out the pain, what aggravate the pain, what release the pain, what is the quality of the pain, what are the timings at which it starts, or what are the factors that aggravate and relieve that pain. Next, we have also the A of the history, which is allergies. Always ask for the allergies. If the patient has any allergies to the medicine, they may have exposure to that. So it's an important question to ask for allergies and to avoid those drugs so we should not use them accidentally if the patient is allergic to those drugs. Then we have any medications patient is taking. Previous or past medical history is important. If the patient, that gives us the idea that patient might have, if there is a history of diabetes, the patient is in coma right now, that can give us the indication that patient might be in the diabetic coma or shock. So history is important, especially if there is some attendant with the patient and patient is not conscious. We need to ask the question because maybe they're a very close relative. They know if there is any past medical history. Then we have any last meal. Maybe patient is hypoglycemic, they didn't eat, and what time the last meal was taken, if we need to go for emergency surgery. So that's also important. Tetanus status, whether they have tetanus or not in any vaccination, immunization. Then other associated symptoms, any operation in the past, and also events, emergency medical system and any environment. So that's also important. What was the environment where they were present when the condition occurs? So these are some important questions to ask in the history of the patient. Now, the key associated symptoms are the cardiopulmonary symptoms like cough, dyspnea, orthopnea. Orthopnea is shortness of the breath when patient is laying down. So we need to put the pillows under the head to make the breathing little easy. Very, very important symptom in cardiopulmonary disorders or patient who have heart problems or a heart failure. So dyspnea is difficulty in breathing. Cough is also the symptom of cardiopulmonary disorder, not just the lungs problem or pulmonary disorder, but the heart associated symptom also. Palpitations, awareness of the heartbeat, palpitations, dizziness, syncope and chest pain. So all these different symptoms when present they gives the idea that there is cardiopulmonary abnormality. Then we have gastrointestinal symptoms that are present when patient who visit the emergency department. Abdominal pain, very important, nausea, vomiting, anorexia, constipation, diarrhea, and bleeding. So all these are different gastrointestinal symptoms. Genitourinary symptoms, dysuria, difficulty in urination, frequency, urgency. The frequency of urination is increased and urgency, if patient feels the urge to urinate or micturate. So there is urgency. Hematuria, blood in the urine, is very, very important symptom. Always pay attention if there is blood coming in the urine. Pneumaturia, presence of air in the urine. Pneumo is for the air, so pneumaturia is air in the urine. Some obstetric gynecological symptoms. Pregnancy, infertility, menses, menarche, contraception, sexual history, vaginal discharge or bleeding, dyspareunia. So these are some symptoms that are obstetric and gynae related. Previous surgeries, previous hysterectomies done, and all other surgeries that can be associated with gynae. Recent procedures that can be performed. And any pelvic infections, pelvic inflammatory disease, pelvic infections can lead to the adhesion, scar formation. That is very common reason for emergency visits that can occur with severe abdominal pain and obstruction. Neurologic symptoms that can be present, we have weakness. Patient will come and say, I have weakness of the right side, I cannot grab things, and there is also pains, difficulty in speaking, concentrating, swallowing, thinking. Imbalance, which can be sensory or motor due to sensory or motor changes, visual problems and headaches. Then 10 warning signs in the history of the patient: sudden onset of symptoms, worsening of the symptoms. Is both these are the warning signs. I have sudden chest pain, that's important. Worsening of the symptoms, something is present for a while and then suddenly it becomes really, really very bad or severe. True loss or alteration of consciousness. Loss of consciousness is always important, need to follow up and work out. Cardiopulmonary symptoms, and now we know all the warning signs which are associated with cardiopulmonary symptoms, like if there is dyspnea, if there is orthopnea, palpitations, patient need to be very carefully monitored. Extremes of age, very young, very old, that's again the warning sign. Their ability to fight the disease is less, so they should be monitored very carefully. Immune compromise, patients who are immunosuppressed, they have difficulty, they have low immunity, they need to follow up properly. Immune compromise is important. Poor historian, person who does not know the history very well, whether they have dementia, they have Alzheimer's, very old age, they will, when you will ask them, okay, when this thing happens or when it started, they will say, oh, maybe the last year, sometime last month. So they don't know exactly what's going on. So that's where the term poor historian comes from. Repeated visit to clinic or emergency department, that's the other warning sign. Incomplete immunization. So if there is incomplete immunization, these are all the warning signs in the history of the patient. Patient sign over at the end of the shift. That was all about section 1. Thank you for watching sqadia.com.